that you can examine it other than the mammogram and the ultrasound? Do you have to do a biopsy? Do you do a needle aspiration? I mean,
it depends on what it looks like.
It depends on the lump itself.
Absolutely, and that's why most breast surgeons use breast ultrasound. We scan our patients ourselves, and part of it is when you feel a lump in the breast, and I can actually take the ultrasound probe. I often call the ultrasound probe the extension of the surgeon's fingers. It allows me to correlate on the screen with ultrasound waves what I feel with my hands. Sometimes I might do a fine needle aspiration, which is a tiny needle to take cells from it. Sometimes I may recommend a core biopsy. And sometimes, if I believe it's a change in the breast through a menstrual cycle, I may have the patient come back 3 months later, because as you become perimenopausal, your breast can start to change a little bit. And not that you're jumping the gun, but if I think something is suspicious enough, I'd recommend a biopsy right away.
Let's say it is suspicious and our worst fears come back, either through one of these technologies, and you determine, yes, this is cancerous. Are there various stages at which it could come back, or does it always start at stage 1? Do you sometimes find it at stage 4? You
can find cancers at all different stages, and a lot of it depends upon the level of surveillance that someone has participated in. If you get your annual mammograms, you're doing your monthly breast self-exams, you get your annual clinical exam by your gynecologist, those are the women that typically will be diagnosed at an earlier stage because they've gone through that process.
I've had so many people on this show like that who were relatively young, right, or had stage 1, and now they're fine, thank goodness, because it was caught early.
Right. And we know that mammography does not prevent breast cancer, but screening mammography can decrease the risk of dying from breast cancer by 40%. And that's a big number. I mean, when you think about being able to find cancers early, when you can find tiny little flecks of calcium on a mammography, right, that are the first signs of a cancer, you then have the opportunity to be able to find something so incredibly early that it may not need chemotherapy, you may not need to have your breast removed, you may be able to have a lumpectomy and radiation, you may be able to have minimal treatment because you've been doing the right things. Now, even women that do the right things, there are some forms of cancer that do grow very, very fast. And from a 6-month point to another point, a lump can show up out of nowhere, and it doesn't mean that this woman has done anything wrong or has been negligent. There are some really bad guy cancers that just show up.
And there's no way to know or determine who will be a victim of one of these aggressive cancers.
Correct. One of the things that we do know now, and it's kind of a change in thinking from several years ago, there's a form of breast cancer, a basal cancer or triple negative, where we look at the cell surface expression of these specific things: estrogen, progesterone receptors, and HER2 status. A lot of women will hear these things, and when you go online, you see it a lot of times, and people don't quite understand what that means. If you have receptors on the surface of a cancer that express estrogen, progesterone, and HER2, we have targeted medications that are anti-estrogens and a drug called Herceptin. For cancers that are negative, ER, PR, HER2 negative, or triple negative cancers, those cancers tend to be faster growing, more aggressive, and we do not have, at this point, a targeted therapy. So for those cancers, we know that women that have those cancers, if you carry the BRCA1 breast cancer gene, right, 60% of those women that carry that gene will develop that kind of cancer. Therefore, we need to educate women about who's at risk for potentially having the gene so that if you carry that gene, we can find it early.
Well, that's what we're going to tell them about in our next segment, what you can be doing to protect yourself and what you should look for if, in fact, you've gotten that diagnosis that you do have breast cancer. We'll be back with more right after this.
Transportation for It's Your Call guests provided by Preferred Car and Limousine.
Welcome back, everyone. I'm Lynn Doyle, and as part of our continuing coverage of Breast Cancer Awareness Month, we are continuing in a series of programs that we've done to educate you about the latest in breast cancer treatment and research. For that, we've asked our good friend, Dr. Beth Dupree, to join us. She is now with Holy Redeemer Hospital and is sharing her knowledge with us about the latest treatments. I said, if someone does get that god-awful diagnosis that, yes, it's breast cancer, 20, 30 years ago, they would have immediately thought, I'm going to die. Now, if you have to give that diagnosis to a patient, can you reassure them that the chances they'll live will be good?
We have, number one, early detection and diagnosis has led to a far greater opportunity to cure breast cancer or to find it in its early stages. And the earlier you find it, the better off it is. But the other thing is, even cancers that we find that may be more aggressive, 10 years ago we didn't have the drug Herceptin. And now we know that tumors that express this cell surface antigen, we have a drug that's a targeted therapy. Several of my patients were in a clinical trial that years ago we couldn't get the drug. Now it's become part of our standard treatment, and it has created the opportunity to alleviate those cancers that otherwise weren't treated.
We have some questions from Facebook, and one of them is, are all breast cancers the same? And the woman was actually kind of hesitant to ask that question because she said, I don't want to appear stupid, but she really doesn't know if there are different kinds of breast cancers.
Well, this is what makes breast cancer so difficult. There are so many breast cancer types and so many subtypes. We have cancers that start in the ducts, we have cancers that start in the lobules, we have cancers called inflammatory breast cancers that begin as a change in the skin that we never see on a mammography ahead of time. And so with each of those cancers, every tumor has its own makeup, meaning one of them could be estrogen positive, one can be estrogen negative. They can be high grade, they can be low grade. There's so many subtypes that it's not as though we can find one spot and turn it off. We absolutely have such a wide variety of cancer types that we have to do specific therapies for each individual patient.
So there is specific therapy
Absolutely.
for each kind of breast cancer that exists.
And that's why having a comprehensive approach where you have a radiation oncologist, a medical oncologist, a surgeon, and everyone working together so that as we collaborate, we give the patient the best care that we know for that particular tumor.
Is there any type of uniform treatment? I mean, if you get a diagnosis of breast cancer, does it mean you necessarily have to have chemo or you definitely have to have surgery?
Not necessarily. Pretty much everybody needs to have surgery for breast cancer, whether it's a lumpectomy and evaluating the sentinel lymph node, which is testing the lymph node that has the highest risk of spread, whether it's radiation therapy. Each cancer has to be treated. There are some non-invasive breast cancers that are found so early, you can just remove the cancer and not have to give radiation therapy. And we know that now. Years ago, a lot of patients got radiation just because it was cancer, but now we know that if we have a wide enough rim of tissue around it, we don't necessarily have to do that.
Do you always have to remove the breast? If a woman hears breast cancer, does it mean she will lose her breast?
No, absolutely not.
That's probably the best news people will hear.